Chapter 11, which is Principles of Pharmacology. When we couple pathophysiology with the treatments that go along with it, we generally are referring to pharmacology. In most cases, treatments that we do, particularly in EMS, are a medication or a drug. Occasionally, we also use something like electrical therapy when it comes to at least talking about most medical emergencies, as opposed to traumatic emergencies, where in many cases it's really more of a structural issue that we do. So, again, watching this lecture, watching and listening to this lecture is no replacement to actually reading and studying the chapter. You will note that in your textbook, they refer to this as a new section for the class's purposes. Pharmacology, medication, administration, pathophysiology are all kind of clumped in there together. Although we've already covered the administration of medications, so now let's talk about why we're going to do it. The ED standard that goes with this is the AEMT applies fundamental knowledge of medications in the AEMT scope of practice to patient assessment and management. You have a significant number of, I guess not too terrible, about 13 different objectives that are covered in your text on 264 and 265. All right, so AEMTs are responsible for administering medications to ill and injured patients, and some medications administered incorrectly produce life-threatening consequences. All medications have consequences, period. Even oxygen can be harmful. So there's no such thing as the perfectly safe medication. It just doesn't happen. People can overdose on water. You can become water intoxicated. So we cannot say that we can give anything with 100% certainty that nothing bad will happen to that person, because that just doesn't happen. People have reactions. People sometimes we make mistakes, and by us making mistakes, we can sometimes have some pretty negative consequences for our patients. So, to have an understanding of pharmacology. Pharmacology is the study of origin, nature, properties, actions of drugs, and their effects on living organisms. So basically it's saying, we're looking at drugs, and what do they do to everybody, and how did we get to that point? That goes with your case study in the chapter. So, the sources of medications. The four basic sources of medications, which you should be able to find those on 266 in your textbook. We have plants, animals, minerals, and synthetics. So, meaning we get them from, 3 of them come from our environment, and 1 of them, synthetic, is something that we make. So, some examples of these plants. There's a large number of plants that we get medications from. The basic elements of aspirin are found within the willow tree. There's a drug called atropine, which if you are familiar with the antidote kits that you might have in your ambulance for nerve gas poisoning and whatnot, atropine is in there. Atropine is actually a alkaloid of the belladonna plant. We have a medication that a lot of people are on called digoxin or digitalis. That comes from the foxglove plant, which is a very pretty flower. So there's a large number of plant sources that we get these medications from. Animal sources, there is insulin. Insulin comes from various animals. We've now also been able to make that synthetically with human DNA to make it a little bit more appropriate for human use. Minerals, we obviously will get a lot of our electrolytes from certain minerals, so potassiums and calciums and whatnot. Get that from minerals, and then synthetics are the things that we make. So there's all kinds of different ways that we arrive at some of these medications. Some of them were a folk remedy that were found to have some healing properties. Nitroglycerin was actually a mistake. The drug nitroglycerin was the man that invented the explosive nitroglycerin, or trinitrotoluene, noticed that he would have chest pain, and whenever he would be out in his lab working with his new invention, his chest pain would go away, and sometimes he'd get a little lightheaded. And so hence found some of the properties of nitroglycerin that we give. It is technically really in the base form the same stuff as the explosive. So that's why you should never have your patients bite down on a nitroglycerin tablet. Their head will explode. No, just kidding. So they're sometimes found by accident. Sometimes they're folk remedies. Sometimes we actually set out to try to find something specifically. There are some other stories of accidental finds on drugs. Take, for example, Viagra. Everybody associates Viagra with gentlemen with erectile dysfunction, but there certainly are a number of people who don't fit that category. In fact, I hauled a 5-year-old girl on Viagra once. Viagra was actually invented for a disease called pulmonary hypertension. It helps to dilate the vessels of the pulmonary tree, so it reduces the pressures within. Well, it just so happened that when they also gave it to men, that men would commonly get an erection, and therefore the drug companies thought, hey, that'll sell a heck of a lot better than a pulmonary hypertension drug. Still given for pulmonary hypertension, just all the attention is on the other reason why people get it. So in 1921, they discovered insulin, and it saved the lives of over 15 million people with diabetes. Many of this come from pig or cow sources. However, there are the synthetic sources of humulin, which is a purified derivative of human DNA, is where that comes from. If you would really like to think of another gross animal source of drugs, there's the drug Premarin. Premarin, P-R-E-M-A-R-I-N. Premarin is given for ladies in menopause. It is a hormone replacement for their lost estrogen, and it is actually gathered from pregnant, P-R-E, mare, M-A-R, urine, I-N, pregnant mare urine, or pregnant female horse urine is where that substance is derived from. So being familiar with your medications is obviously important. Those of us that are in the smartphone world, I highly recommend that you get some sort of a drug reference on your smartphone. There's a number of them that are free. One that is very commonly used is Epocrates. I'll put a note in the course page about a couple of these, but Epocrates is a very common one. It's free. It's got all kinds of information, more information than we even need. There is also the, I believe Medscape is the other common one that gets used, or Micromedics, correction, not Medscape, Micromedics. That's another very commonly used one. Like I said, I'll put a link to those in the course page. But that you can use to keep current. Now, often people will also carry the pocket guide, pocket flip guides. It gives them a little bit of a quick review on the certain medications and helps you remember some of the more common points of it. There's all kinds of textbooks. There's all kinds of manuals and nurse drug guides and whatnot. There's a copy of a sample medication guide in the course page. It should be up in the top, up with the syllabus and whatnot, that you guys should have and use throughout the course. And then you also should be aware of things like the physician's desk reference, the PDR. The physician's desk reference has, if there's something to be known about that drug, like including how the crystalline structure is, and it is found in the PDR. The PDR is a huge book. Next time you're in, say, the doctor's office or the hospital doing clinicals, ask them where the PDR is and take a look at that. Very fine print on very thin paper, but it has all there is to know about that drug. There's also the drug pamphlets or leaflets that come within the packages of the drugs, and that has tons and tons of information on it. The American Medical Association drug evaluations, the Food and Drug Administration often has a lot of information. rxlist.com is also very helpful, and then any hospital formularies or service formularies. So before administering any drug, you really need to know the basic information about it. And you have to keep current by reviewing your new information regularly. That's why going to continuing education, going to in-services is important. Refresher courses. There are many different printed and electronic resources that you can use to help stay up to date and current. Watch the journals, GEMS and EMS World. They often have discussions on medications in there, and there's great resources for you to use out there. And drugs change. Drugs change over time. So the medication profile. The medication profile has some key information to administer medications safely. Of that, it usually has at least 2 of the 3 names. Each drug has at least 3 names that we use, and that is the generic name, the trade name, and the chemical name of the drug. We typically do not use the chemical name of the drug because it is it's more than a mouthful by many means. I'm just going to find an example here. I think we've got a spot in the book in which we could take a better look at some of these drugs. No, they don't list the chemical name, but the chemical names usually are extremely long. Basis name for the medication. It's then the generic name that is then derived from the chemical name, and the generic name is what every company calls it. The trade name is also better known as the brand name. Is what is that drug called otherwise. So if we take, for example, some common everyday items, the generic name of a product, facial tissue, the brand name made by a certain company is Kleenex, although we most of the time everybody call it Kleenex. But remember, there's also Puffs, there's various other producers, but they're all facial tissues. So, Cola would be the generic name, Coke, Pepsi, RC, whatever. So you get the point. I make it a point to try to always use the generic name because the generic name is printed on every package that you could possibly need. Some drugs, the brand name, the company that creates the trade name or the brand name, that's the only company for a while. A lot of times it's for, say, up to 10 years. So we'll take, for example, one that people may be familiar with, Claritin. Claritin is commonly used for allergies, seasonal allergies, and environmental allergies. For the longest time, Claritin was the only way you could get that drug. There was not an off-brand to it. There was not a generic version of it you could get. So, a lot of people just called it Claritin, although the correct name of it is loratadine, and now there are plenty of companies that make loratadine because that has come off of its copyright and trademark. So it is able to be made by the generics now. So naloxone is a generic name, Narcan, trade name. Epinephrine, generic name. Adrenaline, it's a trade name. Oral glucose, generic name. Glucose or instant glucose is a trade name. Aspirin is a generic name, or acetylsalicylic acid, also a generic name. Bayer would be a trade name. Then we talk about the classification. That classification of the medication is, what does it do? Okay, and it may have several different classifications. It may fit into a couple of different categories of what drug family is probably a good way to say it, does it work on. So we're also going to look at the mechanism of action that goes along with the classification and what body system it works on. So we may have drugs that do multiple things. We'll take, for example, glucagon. Glucagon is usually used for patients who have hypoglycemia and we can't get an IV to get them some sugar. However, it just so happens that glucagon also is a esophageal dilator. So sometimes people with something stuck in their esophagus will be given glucagon to help remove that blockage or that obstruction in their esophagus. So it could fit in a couple of different categories. So the mechanism of action, which is very important for us to know, the mechanism of action is actually, what does it do once we put it in the body? So maybe it's a vasodilator like nitroglycerin. Nitroglycerin is a vasodilator, so it goes in and it expands the vessels. Aspirin. Aspirin has obviously a couple ways. It's an antipyretic, so it helps to break the fever. But in the cases in which we're giving it for cardiac patients, it is an antiplatelet, so it keeps the platelets from sticking together. And so, yes, that mechanism of action, the way that it achieves its intended effects. So what does it do? Sometimes they're very simple, like dextrose 50%. It's a nutrient. We push it in, the body uses it up. It's the body's base fuel. Oxygen. It is a gas necessary for life. So sometimes they're very easy. Sometimes they're very complex. How exactly do they get to what they're trying to do? An indication is when that medication should be given. What is it intended to treat? Dextrose 50% is intended to treat patients with hypoglycemia or low blood sugar. Naloxone is intended to treat patients with opioid overdose with respiratory depression. Nitroglycerin intended to treat patients with cardiac-related chest discomfort. There are also the pharmacokinetics of it. And the pharmacokinetics of it is how does the body use it, distribute it, and get rid of it. So is it absorbed through the mucous membrane? Is it absorbed, taken up through the gastrointestinal tract, through the bloodstream? What area of the body then does it go and work on? And it may be very, very, very precise on a very specific receptor, maybe a very specific hormone that it works with. And then how is it eliminated? Is it eliminated in the feces, in the urine? And how long does it take for it to get rid of it? Things called half-life and so on and so forth. Side effects. There are side effects which are unintended effects of the medication. For example, one side effect of nitroglycerin is usually it gives patients a headache. And then we can also have an untoward effect, a side effect with negative impact on the body such as hypotension. So or they'll also sometimes call those adverse effects. So nitroglycerin can also cause you to have hypotension. A headache is a bother. Hypotension is a problem. The route of administration. Which way do we give this drug? How is it introduced into the body? And many medications have more than one route depending on what you're trying to do. So nitroglycerin, like they show in the textbook, you typically give it sublingual under the tongue. There's a transdermal route, which you can put a nitro patch or paste on. There's also oral versions of it. It's not usually listed specifically as nitroglycerin. It's a little bit different. We can give nitroglycerin IV. At the paramedic level, you can give it IV. So there's lots of different forms to give it. Narcan or naloxone, you can give it in so many different ways. IV, sub-Q, IM, probably would even work sublingually. You can squirt it up their nose. You can squirt it down the ET tube. You could probably put it in a nebulizer and it would work. Narcan, it can be given, and there is an oral version. There's a pill version of it. So there's so many different possible ways to give that. And those are all the different routes of administration. Contraindication. This is when you should not give this drug. It makes administration of this drug harmful, even though it otherwise may be indicated for a medical problem. We'll take nitroglycerin again for an example. If the patient is already hypotensive, we do not want to give them nitroglycerin. So depending on what your protocol is, either the systolic blood pressure of 90 or 100, we do not give nitroglycerin if the blood pressure is too low. It's going to continue to make them tank their blood pressure. The dose. How much are we going to give them? And all of those lovely med math problems that keep popping up in this class all have to do with the dose. So the dose is how much do we give. But in addition to that is also how often. So can we give, everybody is probably aware that you give nitroglycerin, 0.4 milligrams nitroglycerin sublingually every 3 to 5 minutes to a total dose of 3 doses. Depending on your protocol might say no more often than 5 minutes apart. But every 3 to 5, total dose of 3. So no more than 3 doses. How it's supplied. This is the packaging. Packaging and the concentration. This is important. While we don't always list packaging and concentration in all the drug profiles that we have, it's just simply because it's going to depend on what company made what at what time. So there's some of the more common ones that we might have to be concerned with. Aspirin obviously comes in the 325 version and the 81 milligram version. Epinephrine 1 to 1,000, the version that you guys and AEMTs can use, and epinephrine 1 to 10,000 is the version that's given IV by paramedics, doctors, and nurses. Narcan. Sometimes you get naloxone in an amp of 0.4 milligrams. Sometimes you get it in 2 milligrams and 2 mLs. So it behooves you to take the extra time to know what are you carrying, what's in your bag, so it doesn't surprise you when it comes time to give it. In most cases, we can rely fairly comfortably on knowing a certain color that corresponds with a certain medication, such as most packaging for D50 is a medium to light blue in color. Most of the drug companies have picked that up. Most naloxone is kind of a peachy orange color. Epinephrine typically is kind of a gray. Aspirin doesn't usually have a corresponding color to it. Glucagon depends on the way it comes packaged. A lot of times it comes in a plastic case that's red. So a lot of times we can kind of stick to that and go with what we know. But it never is an excuse for you to not double check, triple check, all your 6 rights to make sure that this is in fact what we want. And then any special considerations. So are there any things that we need to know specifically about this? Give a different amount to a specific patient population, maybe a pediatric patient. Most people think, oh, well, we give less to pediatric patients. That's not true. In some meds, we give the pediatric patient a higher dose per kilogram than we would an adult. Good example of when we go to paralyzed patients to intubate them. Pediatrics usually require more than adults do. Maybe it's a pregnant patient. There's pregnancy categories. And as you look at pregnancy categories, a real quick way to think about these is similar to a school grading system. A through D, and A is great, so it's fine to give a pregnant patient anything that's an A, a pregnancy category A. D, not so great. It's not that you can't give it, but it's probably has some considerable dangers doing that. And then the last one, instead of having an F, think of it as a movie rating X. If there's an X, then no way. X is proven, I mean, it's almost guaranteed that you give that pregnant patient a category X medication, that there is going to be an issue, particularly with the baby. So keeping that in mind, sometimes we have these special considerations. Some of them might also note the way that you have to store it. Some medications have to be refrigerated. Some medications have to be protected from heat and light. So, for example, nitroglycerin. Nitroglycerin doesn't get along with anything. There's hardly another medication out there that nitro is compatible with. There's a few. Heparin happens to be one, but many medications non-compatible. And nitroglycerin doesn't like light, it doesn't like heat, it doesn't like air. So that's why it comes in a dark bottle inside a box and with a cap on it. And anybody who just leaves their nitro laying around with the cap off, they're destroying their nitro. It denatures very quickly and becomes useless little powdered pills. So as an AEMT, you will be responsible for the administration of some over-the-counter medications. You don't always have to have a prescription medication, but if your medical direction says that you can give people ibuprofen or oral Benadryl, you can get that. Go to the store and buy Benadryl at the store in pill form or liquid form. And as long as your medical director is okay with that, you can give that to the allergic reaction patient. So even though they're over-the-counter, though, you can still only use them by protocol. You have to have permission to give those drugs. So be very aware and explicit to what you can and cannot do, what you can and cannot give when it comes to medications. So medication oversight and regulation. Pharmaceutical manufacturers adhere to the laws and regulations that protect the consumer. Yes, it is a very long, tedious, and arduous process to get medications approved in the United States. We have very high standards in the United States on how they have to be produced and tested, and facilities, because they want them to be the most the cleanest, the safest, the best for the patient. Other countries in the world, they don't have nearly the standards that we do. So you may be getting pills that are contaminated. You may be getting pills that aren't as pure as we believed. They're not as concentrated as they should be. But there's a lot of oversight. We're required to provide the public with information and marketing of the medication so consumers can make informed decisions. So when consumers go to purchase and use a medication, that's why we get all that packaging that comes with it, all those flyers and whatnot. So the consumer can read through it and decide, is this going to be right for me? And that's why we always have pages upon pages of disclaimers that this could cause this can cause that. And it's so the consumer can know everything that there is to know. There's nothing hidden from them. Maybe a little bit more difficult to understand because it's written in medicalese, but it's available to them to then question. When it comes to legislation, it protects the public from unsafe and mislabeled meds. In the United States Food and Drug Administration, or the FDA, oversees the medication production and distribution process, and they have many laws that are in place. For example, as an AEMT, you can't just go walk into a Walgreens and buy a Narcan off the shelf. That requires a prescription. Even though you're a medical provider, your physician medical director has to sign a prescription authorization form with your supplying company, whether you use like Boundtree or something along those lines, that allows you to actually order and use those medications. There's different levels of protection there in case the controlled substances or the scheduled drugs. So legislation has also been enacted. There's tons and tons of legislation that's come in over time. You can read all about this great legislation on page 267 in your textbook. And it talks about the various acts that have come into place, going all the way back to the Pure Food and Drug Pure Food and Drug Act of 1906. Which ensured proper labeling. The Harrison Narcotic Act of 1914 talked about the use of addictive drugs, and it just continued and has gone on and on and on. And we have all kinds of different amendments, acts, and laws that are in place to help make sure that medication doesn't get into the wrong hands. Medication labels include addictive drugs as well. There's a list of potential side effects of the medication. Those things have to be made clear. AEMT's responsibility to perform the assessment and identify the need for the medication administration. Just because we can do it doesn't mean we should do it. Sometimes we have to weigh the consequences versus the benefits. You can purchase those over-the-counter medications without a prescription. However, you have to, again, have approval from your medical director to actually give those. And they'd be familiar with the regulations of your state and your employer. So you're going to need to know, how do these have to be stored? Where can we store them? What is it that, how is it we're going to actually administer them? Now, we have some controlled substances. You'll find this on page 268 in your textbook. This is the 5 levels of scheduled drugs. And scheduled drugs are also called controlled substances. The scheduled drugs are based off of how addictive they are, and as well as how potentially beneficial they are. Schedule 1 drugs have no medical use, and they are highly addictive. And have a high potential for abuse. So you can see their examples: heroin, LSD, mescaline, methylqualone. Those drugs are Schedule 1. There is no need for them. At one time they believed that they were medicinal, but they ended up, they don't do anything of medical value. They may make you feel weird or better or whatever, but they're highly addictive, have no medical use. Schedule 2, still very highly addictive, but do have a good medical use for them. These medications, they require a written prescription. They're restricted from phone renewals, so you've got to come in with a written prescription. Require the oversight by a physician, and abuse can result in severe physical and or psychological dependence. So common Schedule 2 drugs include morphine, codeine, meperidine, hydrocodone. Cocaine actually does fall in here, as does amphetamines in some cases, because they actually do have medical use. Cocaine is actually used in the treatment, oddly enough, of nosebleeds. So Schedule 3, these have a lesser abuse potential than Schedule IIs. They can still result in a kind of an ugly dependence. These are some drugs that probably have less pain-killing properties in most cases, such as anabolic steroids, or you can have some non-prescription painkillers that are combined with a Schedule II, so Tylenol with codeine, if anybody's been on that, or that often gets called Tylenol 3. That is a Schedule III medication because it's a little bit of codeine added to your Tylenol. Schedule IV, even a less potential for abuse. However, they can still cause some dependencies. The benzodiazepines typically fall in here, some of the barbiturates and the stimulants. So you may have some of your amphetamines such as Ritalin, which falls here. Benzodiazepines such as Valium and Versed fall as Schedule IV. Ativan falls in there. Barbiturates, phenobarbital, which gets used for treatment of seizures. However, they also is a feel-good drug, falls under Schedule IV. And then finally Schedule V. These medications have less abuse potential than Schedule IV. They are accepted medically for use, and they have a even less likely probability of dependence. So over-the-counter medications for, say, cough, antidiarrheal medications with a small amount of controlled substances. Sometimes codeine gets used in some of these things, so that would be a Schedule V medication. Safety and regulation, again, done by the FDA, Food and Drug Administration. They're going to test it. They're going to require additional testing from the company that's producing it to make sure that it is safe. They also look into food safety as well, and they will test various medical devices and cosmetics. So when, say, a new defibrillator comes on the market, the FDA also oversees its testing. Talked about that special consideration. The pregnant patient causes some different changes to anatomy and physiology. The biggest thing is the risk of the fetus. And again, here are those FDA pregnancy categories. Again, it's A through D. Basically, the A is great, really should be no issues. D is, it's risky, but there might be a time in which it's okay. And then X, absolutely not. You should not do this. Really, really should not give this because the fetus is most likely going to suffer. Pediatric patients, we have obviously differences in anatomy and physiology between peds and adults, and the differences on how these medications are going to affect. Some oddball things that happen in most adults, if we take some Benadryl or some diphenhydramine, which is the generic name of that. We take diphenhydramine, most adults, we're getting sleepy. A lot of times in smaller children, you give them diphenhydramine and they get hyper. So we sometimes see that opposite effect or a paradox. And then many pediatric drugs are also weight-based until they reach a certain size. Say, it's usually once they get to about they've hit puberty and they've, in their growth state, that we're going to steer clear of weight-based. Geriatric patients, there's obviously differences in the way they absorb, distribute, metabolize, and eliminate their medication. And then oftentimes they have tons and tons of medical conditions. They may be on other medications that will have some potentially negative side effects that go along with it. Been talking about those. All right, so how many names do most medications have and what are they? Well, we talked about 3 of the actual 4 medication names. There is technically a 4th medication name, but it is usually the same as the generic name, just with USP added on the end of it. USP means United States Pharmacopoeia, which is the master book of drugs in the United States. So we have a generic name, official name, which is with the USP. We have the generic name, which is what we most commonly know it as. We have the chemical name, and if you're looking on 270 in your text, here's what I was thinking of earlier. That shows you the chemical name for albuterol. I'm not even going to attempt that. So, and the trade name being Proventil, or Venolin is another one. Oh, there they are right there. Alpha-1 tert butyl amino methyl 4-hydroxy M-xylene alpha prime diol sulfate 2-to-1 salt. There'll be a test on that. No, not really. So talk a little bit more about medication forms and what sort of forms do we get our different meds in. Well, there's lots of different potential forms they'll come in. Our solid medications will be usually tablets, capsules, or powders. Tablets can be powders that are compressed into a basically solid unit. They're formed together under high pressure. Capsules are usually the powdered or solid medication that's encased in usually a gel coating. And then powders, of course, would be non-compressed solid form. Sometimes powders are swallowed, sometimes they're absorbed underneath the tongue, and sometimes they may even be inhaled. Certain inhalers don't actually have a liquid form of the drug, they have a powdered form of the drug that is inhaled. Liquid medications, there's different forms and different names for different types of medications that come in liquid format, and some of them you probably never even thought twice about. But remember that liquid medications are a solution, and a solution is a solid medication, which is the solute, and the liquid that it's dissolved in, which is the solvent. So we can think of solvents as things that dissolve other things. But the solute and the solvent create a solution. And it is that liquid mixture of the medium that it all floats in and the medication that is in it. These are given in tons and tons of different routes. But just briefly, suspensions. These consist of substances that don't dissolve well in liquids, and those substances are ground into fine particles and can be well distributed in a liquid when shaken or stirred. I like to think of like your oily Italian salad dressing as a suspension. You shake that the oily Italian up to resuspend everything in there. After you leave it sit on the counter for a while or in the fridge for a while, it settles out. So that's a suspension. A tincture is uses alcohol in the process and usually is a topical application. So it's something that's intended to be absorbed through the skin. Spirits. Spirits are meant to be taken orally, and these are also a medication in alcohol. So tinctures are alcohol for the topical. Spirits are alcohol meant to be ingested. We can also have elixirs. Elixirs are produced by mixing a medication with a sweetener or a flavor for oral administration. So a lot of cough elixirs, cough syrups are probably also considered elixirs. Then we have syrups. These are mixtures of medications with a thick, sweet flavor to improve the taste of the medication. And then finally, emulsions. It's a combination of two liquids that are not soluble, and they're typically emulsions consist of an oil and a water. Emulsions tend to be thicker than suspensions do. And we can also have some semi-solid medications, such as lotions, creams, gels, ointments, and medicated adhesive patches. So Basically, the way that they are structured, the amount of water that they have in them versus the different oils, and how quickly they can be absorbed, and for how much of their body they're intended to be on. Lotions, lotions, creams, and ointments all have different amounts of water and oil and different absorption rates. Lotions tend to be absorbed quickly. Creams and gels tend to take a little bit longer. And then ointments we may not really want to absorb quickly. We may want it to stay around for a while, say like a triple antibiotic ointment, or what most people would call Neosporin. And then we have medicated adhesive patches or topical drugs, transcutaneous drugs, so nitro patch, a morphine patch, a fentanyl patch, where it is basically like a Band-Aid with medication stuck on it. So we have gases. Couple of gases that are intended to be breathed into the lung. They're almost immediately absorbed into the bloodstream. And we have two major gases that we give in EMS, both oxygen and nitrous oxide. More solid or semi-solid medication form that probably should be at least spoke of, although we don't give drugs in this form very commonly in EMS, is that of the, as I like to affectionately refer to it as, the silver bullet, or a suppository. Suppositories typically are wrapped in foil, hence the name silver bullet, but and they're shaped like a bullet because they're tapered on one end for intentionally being placed in a cavity or area such as your rectum. They usually are in a wax base. It is medication in a wax, and that wax melts at body temperature and allows the medication to be absorbed through the mucous membrane in which it is placed. Oddly enough, once in a while people are under the impression that those funny shaped looking little pills that taste like crap are intended to be taken by mouth, when in fact many times they're actually suppositories. So, all right, so many drugs are appropriate for topical administration in adults, are not appropriate for pediatric administration. Why might this be the case? Well, the vasculature of an adult as well as the body weight of an adult can alter the absorption of that drug, and with the pediatric population that wasn't the intended recipient of that drug, they could have a very odd reaction to that. So classifications of medications. So medications that affect the nervous system. This is when we're going to really start throwing some terms at you, and it has the potential to kind of get messy here. So you may want to consider going through this several times to get this all straight. All right, so we have medications that affect the nervous system. The sympathetic, remember fight or flight. We have sympathomimetics, or also sometimes called adrenergic agonists. Either one is appropriate. Sympathomimetic, or an agonist. An agonist is a supporter, a helper, a mimicker. So sympathomimetic or adrenergic agonist. This simulates the sympathetic nervous system. So a good example of a adrenergic agonist would be epinephrine. Epinephrine is one of the primary hormones of the sympathetic nervous system. So this is a sympathomimetic or an adrenergic agonist. We could also have a sympatholytic or an adrenergic antagonist. We don't tend to have many of those, but there is a few. Not something we would commonly give in EMS. An antagonist or a lytic is against. So as we look down to parasympathetic nervous system, where we have the rest and digest, a parasympathomimetic or a cholinergic agent, either of those, is supporting the parasympathetic, so making you rest, making you digest. A parasympatholytic or an anticholinergic agent or a antagonist would be against that. So it would be actually more, it would lean more towards the sympathetic side of things than the parasympathetic. So here's the adrenergic receptors and their responses to stimulation. This would be something that you would want to know, something you want to keep in mind. We talk about alpha and we talk about beta. So we have alpha 1, alpha 2, beta 1, beta 2. Alpha 1 receptors cause peripheral vasoconstriction, whereas alpha 2 causes peripheral vasodilation and little to no bronchoconstriction. So you can think we're talking lungs there. When we're talking 2, you got 2 lungs, you got 1 heart. So 2s usually have to do with something with the lungs. 1s tend to have to do with just the heart or the circulatory system. Beta 1 increases the heart rate, increases automaticity or the ability of the heart to create its own electricity. It increases the myocardial contractility, which means it beats harder, and it increases conductivity, or the amount of it makes the electricity flow quicker through the heart. Epinephrine is a prime example of this. It also has a couple of other things that go along with it. It increases the myocardial oxygen demand, and it increases the dilation of the coronary vessels. Beta 2 is a bronchodilator and a vasodilator. So a good example of a beta 2 drug is albuterol. Albuterol causes bronchodilation and causes some vasodilation centrally. It is a beta 2 select agonist. So it doesn't tend to have, it will have some minor effect on the beta 1, but it really primarily affects beta 2. Alright, so a few other things to throw at you here. Medications that reduce pain are analgesics. We may have a variety of different types of analgesics that we are talking about. Whether we're talking about NSAIDs, which are non-steroidal anti-inflammatory drugs, the big one there being ibuprofen. We may also have some other oddball drugs out there, such as aspirin, which doesn't technically classify as an NSAID. It was kind of where they based the model of an NSAID from, but it is not specifically an NSAID. So we also look, if you look on 271 in your text under classifications of medications, they're actually talking a little bit about ibuprofen, that it is an analgesic. It is a non-steroidal anti-inflammatory because it also helps combat the inflammation. It is an antipyretic because it helps with fever. And it is a cyclooxygenase inhibitor, COX-1, COX-2, for any specific mechanisms of action. So depending a lot of times on the amount that we give and for how long is the effects that we tend to get. I think a lot of us have probably taken ibuprofen for headaches, in which we were using it basically as an as an analgesic. But people who have, say, had surgery and for 6 or 8 weeks are on higher doses of ibuprofen are using it for the anti-inflammatory properties. So the non-steroidal anti-inflammatory drugs are those that are not falling into the class of, say, an opioid or a narcotic. So these are generally over-the-counter items. Now there is a couple of prescription NSAIDs. For example, sometimes paramedics will give a drug called ketorolac or Toradol, and that isn't actually, that's like super ibuprofen. But naproxen also falls under the NSAID. Ketoprofen falls under the NSAIDs. Anti-anxiety and sedative hypnotic drugs. So these are designed to reduce your anxieties. Several different families of drugs under this. The barbiturates, the benzodiazepines, and the other non-barbiturate hypnotics fall under that. And so barbiturates, like I mentioned before, we talk about things like phenobarbital. And phenobarbital has to do with, or is commonly used for the treatment of seizures. It's kind of a maintenance drug now. However, it is a drug of abuse that occasionally does get used for purposes of getting high. Benzodiazepines, that tends to be the drugs such as Valium, Versed, and then there are some other oddball non-barbiturate hypnotics that get used for sedation. Things maybe like Ambien, so that's a sleep aid. Backing up to analgesics for a moment, the analgesic that is on the scope of practice for Iowa advanced EMTs is nitrous oxide. Nitrous oxide is an inhaled gas. It is not opioid, and it is self-administered. The patient, it reduces their pain, reduces their anxieties a little bit. So it kind of bridges both the analgesic and the anti-anxiety gap. And but it is self-administered, and as soon as the patient starts to get drowsy enough that their hand falls away with the mask in hand, then they're no longer getting the medication. So you may be given some NSAID drugs if you're allowed to give ibuprofen or maybe even acetaminophen. Right. Stimulant drugs. Stimulants are medications that produce central nervous system excitation. Caffeine, probably the one that we're all very familiar with. However, things such as cocaine and amphetamines are also considered stimulants. We don't routinely give any stimulants in EMS. As far as improving the mental faculties. The drug epinephrine is a stimulant, but used in a different manner. So people are like, well, amphetamine, cocaine. Cocaine actually falls into a couple different classes. Cocaine actually is also an anesthetic, so it reduces pain. Amphetamines, the amphetamine class of drugs is those things like Ritalin, and Ritalin is treated with a stimulant drug to help people get on task and stay on task as opposed to bouncing all over. We may have depressant drugs that slow the CNS activity. You may also be able to pull in there the anti-anxiety and sedative agents to kind of bridge the gap. But the depressants will help treat anxieties, muscle tensions, stress, pains, insomnia. So diazepam, alprazolam, we kind of bridge the gap again because those are actually benzodiazepines that are also working in another manner. We have anticonvulsant drugs. These are anti-seizure or anti-epileptic drugs. And again, diazepam falls here as well, which is diazepam is Valium. It's used in the treatment of seizures. Now, we may also use the barbiturates here. We may use other drugs, say like Dilantin, which fall in here, that help to stabilize these cell membranes and keep them from kind of going into overdrive. We have the psychotherapeutic medications, and there are tons and tons and tons of psychotherapeutic medications out there, most commonly prescribed drugs in the United States. So we have things that treat depression, things that treat anxiety, things that will treat psychotic disorders like schizophrenia. So all of the antipsychotic drugs in particular have the potential to have some odd side effects to them. where people get very, very monotone, and they don't you know they just don't have the excitation. They don't have nearly the emotion that they would. Some of them have sexual side effects, causing anorgasmia, where a person can't have an orgasm, or there may be drugs that cause excessive weight gain. So these psychotherapeutic medications help us feel better, but they don't come without the potential side effects. So you may also see some weird things like EPS, extrapyramidal symptoms, or syndromes, sometimes it's called, that involve like muscle twitching, jerking, tremors, changes in heart and respiratory rate. You'd almost think that they're tweaking off of an illegal drug, but sometimes it's actually a legal prescribed drug to them that's causing them to have some of these weird symptoms. The odd thing about psychotherapeutic drugs is in many cases people get to feeling better, and next thing they know they're like, oh, I feel great. I'm not depressed. I don't need these drugs anymore, so they stop taking them. Well, once they're on them, usually they're on them for some time. Now they may get tapered back down. Most of these drugs should not be stopped cold turkey because they'll cause some very, very odd side effects. And then antidepressants, there are so many different types of antidepressants out there in the world. Most of them help reduce certain hormones from being reabsorbed. They're called select reuptake inhibitors. You might have SSRIs, which are select serotonin reuptake inhibitors, SNRIs, which are norepi reuptake inhibitors. There's older classes of drugs that sometimes get used, such as the MAOIs, which are monoamine oxidase inhibitors, or the cyclic antidepressants, which can be tricyclic antidepressants. Those are older drugs. They worked, but they were much more dangerous than what a lot of our current SNRIs or SSRIs are. Respiratory meds, all kinds of different ones. Sometimes we have over-the-counter ones. There used to be a medication that was advertised on TV all the time. It was Primatene Mist, and Primatene Mist was an inhaler that people could get when they were having some issues with breathing. I think for the most part it's been removed from the market because actually Primatene Mist is inhaled epinephrine, and people were having very, very serious side effects from taking too much inhaled epinephrine. There's others out there on the market, the mucolytics, such as, say, Mucinex, that help break down the mucus. There are plenty of things like inhalers, beta-2 agonists, like the albuterol that we talked about, corticosteroids. So people, you might be familiar, your service might carry a drug called Duoneb. Duoneb is actually a combination of albuterol and another drug called ipratropium bromide. It's those two drugs together that makes Duoneb. It is not in the AEMT scope of practice currently because Duoneb is not a bronchodilator, and AEMTs can give inhaled bronchodilators only. Ipratropium bromide is an anticholinergic agent, so that is why it is not within the scope. That may change in the future. Steroids. There are plenty of people that have respiratory problems that are on steroids, such as Solumedrol, that help them reduce their inflammation. Tons and tons of cardiovascular agents on the market. We have antidysrhythmic agents, which help treat abnormal heart rhythms, antihypertensive meds that keep blood pressure down, antiplatelet and anticoagulant agents that help produce blood clots, fibrinolytic agents which break down the fibrin network of existing blood clots. Fibrinolytics, you're not going to find people that are on fibrinolytic agents, but fibrinolytic agents are when we give the clot-busting drug in the ER for the person that's having a heart attack. That's what we're given. It's a fibrinolytic drug. There are so many other different types of or cardiovascular drugs. You might be talking things: sodium channel blockers, beta blockers, potassium channel blockers, calcium channel blockers, and the list just goes on and on. Antihypertensive agents, it might be something that is just a beta blocker, also falls in the antihypertensive agent, as does a calcium channel blocker. But what those drugs do is they block certain stimulation. They block the stimulation of beta, which causes some peripheral vasoconstriction, as well as causing some increase in heart rate and contractility, so it kind of reduces the heart's ability to work. Diuretic agents such as Lasix. We have vasodilators such as nitroglycerin. It's going to make the vessels get larger. There's a class of antihypertensive drugs called ACE inhibitors, which is angiotensin converting enzyme. When you prevent the conversion of angiotensin 1 to angiotensin 2, you take away the ability for much of that angiotensin to become a very potent vasoconstrictor. We also have those antiplatelet, like I mentioned. Antiplatelet would be something like Plavix. Aspirin also is an antiplatelet agent. They don't break down the clots, they just help reduce their ability to form. They take some of the sticky off the platelets. We'll say that. It's like an old sticky note that you've stuck to something 15 times. It's not quite as sticky as it used to be. Whereas an anticoagulant agent, this helps interrupt some of the other mechanisms in the clotting cascade. The clotting cascade is a complex system of various hormones being released that allow the blood clots to get together, and then the fibrin to form, and so on and so forth. But the anticoagulants such as warfarin or Coumadin, those drugs are anticoagulants. They interrupt something different instead of taking the sticky off the platelet. However, anticoagulants, both anticoagulants and antiplatelets, can cause you to have some excessive bleeding. Anticoagulants are usually much worse. And I talked about the fibrinolytics. TPA and TNK are the major fibrinolytics that you'll hear. I'm not going to dwell on those. We have diabetic agents, whether they be insulins or they be oral hypoglycemics. Insulins are simply a replacement to your insulin hormone. Anti-hypoglycemic agents are, when the people take pills, those pills are not insulin in a pill. The pill is actually something that helps control the blood sugar and keeps them from getting hyperglycemic. So, immunosuppressant agents, whether that is something like a steroid or something a little bigger and badder, we have immunosuppressants used in patients who have gotten an organ transplant, because the body looks at that transplanted organ as foreign tissue and that it should destroy it. So they get put on an immunosuppressant to help reduce that. Also, people who have certain autoimmune diseases like lupus, where their body is attacking its own tissues, they may end up on an immunosuppressant drug. So medications get classified in many different ways by their mechanism of action, by their target tissue, how they treat a condition, and by the body system affected by the drug. So sometimes drugs get used for different things. Depends on what's going on. So packaging. This, I hope, is all basically kind of a review. We touched on a lot of these things during the first skills day. We'll be, I'm sure, touching on them again at the second skills day. This is an example of a pre-filled syringe, and that pre-filled syringe usually comes in a box. I hope everybody had an opportunity to bust one of those open and mess around with one. They come unassembled. So like in the bottom there, you have the barrel with the needle. This one also has a needle adapter on it. And then you have the pre-filled tube and plunger device. You pop the yellow caps off. If you've ever watched Emergency Johnny and Roy, you know that's the best part. You get to flip the caps off, and then you screw the pre-filled tube plunger into the barrel. If you look closely, you can see that in the end of the blue pre-filled tube plunger, there's kind of a threaded. There's threads on the outside of that, and then you can barely kind of see it. If you look into the barrel towards the right, you can kind of see the threads on the inside there that screws together. And then, of course, there's going to be an air bubble in there that we're going to want to tip upright so the needle's pointed up in the air and expel that extra little bit of air that's in there. I guess the interesting part of this package that they've selected here is if you pull on the yellow-green IV needle or IV additive needle, if you pull on that, you can kind of see there's U-shaped little guard, more or less, made out of the barrel. There is an actual needle underneath that green. So you can pull that yellow-green device off of there and you have a needle that you can stick into a regular IV system. Or if you just unscrewed the little yellow knob, more or less, on the green needle additive, you would be able to use that with a needleless system. So it's a multi-purpose. It works pretty well. Here we have vials. These vials, they have self-sealing rubber tops in them. Some of them are multi-dose, such as the epinephrine in the middle. The atropine on the right is probably also multi-use. Naloxone, I wouldn't doubt it if that's not multi-use. Yeah, because there's quite a bit of it in there. Sometimes we have very small vials, 1 or 2 mLs. They're intended for single use. We've got these much bigger vials here. Not as likely to use these in field as they are in the hospital, where they're going to use them much quicker, such as that bottle of naloxone is probably going to be put somewhere in surgery, so if they're trying to wake somebody up after surgery, they can get them woke up quickly with some Narcan. So these usually have the plastic cap over the top of them. Everybody should have seen those hopefully in Skills Day. Otherwise, look at 275 in your textbook, figure 11.3. The guy in his hands has 2 little vials, and they both have the plastic cap on the top of them. And then ampules. Ampules are strictly a one-time use. They're a completely glass packaging. At the neck, they're slightly scored, so they're intended to break fairly nicely. You got to remember to tap any medication that's in the tops of those amps down into the bottom, so you just kind of gently tap it on a surface, and that usually will have the drug drop back down into the bottom there. I recommend when you do that, you put something between you and the glass, and like I at least showed the Council Bluffs students, if you're careful when you rip just the edge off of your alcohol wipe foil, you can pull the alcohol wipe out of there, clean the neck of the ampule, and then take the packaging, which is in theory nearly sterile on the inside, put that over the top of your amp and use that as a way to protect your hands front when you pop the neck of your amps. What we don't have on this PowerPoint that you do have in the textbook, like I mentioned, figure 11.3 on 275, is non-constituted medication. So glucagon comes non-constituted. It requires you to mix a diluent or a liquid with the powdered solute in order to make your solution. The reason they do this is it gives it a longer shelf life. Glucagon doesn't have a very good shelf life to begin with, but if you leave it in a dry powder form and you mix it right before you give it, you get a longer, better shelf life. Glucagon is probably the most expensive drug you're going to carry. It's well over $100 a dose. So saving a little money by having to do a little quick mix when it's not something we give on a regular basis is probably a pretty smart idea. So most medications are packaged to accommodate its intended use. protects the medication during storage. You got to make sure that you carry this in some sort of a box or a bag that keeps it from getting damaged. If it comes in a box, if you can keep it in a box, that's probably a good idea, simply for the fact that light, it can be very hard on medications, particularly say nitroglycerin. Some ideas for carrying medications. You don't need to carry tons and tons of medication. A lot of them are fairly expensive. Some of them are hard to come by, depending on what the shortage is. And you might want to think about something like a small plastic tackle box or small plastic craft box in order to put your medications in. It gives it a little bit more protection. Not that anything ever gets broken in an ambulance, but a lot of our packages are glass, and so we have to be extra cautious that way. So typically in EMS we see pre-filled syringes, say for our naloxone and our D50. We have vials. We may have a vial for either naloxone, probably not epinephrine. Well, if we had a 30 milliliter vial for epinephrine, could be in a vial. Non-constituted would be your glucagon. Ampules, probably your epinephrine, potentially your naloxone. And then nebules, which are basically little plastic packages that your albuterol is most likely going to come in. Of course, you have your standard bottles of pills of aspirin, and then the gas of Narcan or of nitrous oxide and oxygen, and then any over-the-counter drugs you may have, so on and so forth. All right, so since medications can be administered by different routes, they're packaged for their intended use. For example, since epinephrine is administered by injection, it is most commonly supplied in either a pre-filled syringe or an ampule. So pharmacokinetics. This is the branch of pharmacology that's concerned with the way that drugs are absorbed, distributed, metabolized, and eliminated from the body. So absorption, this is the way that the drug is very first introduced into the body. And so whether that is through injection, inhalation, ingestion. Distribution, so the medication enters the circulation, it has to get sent to the target tissue. Most of the time we don't give the drug directly where we need it to work. So say glucagon. Glucagon has to be distributed down to the liver. Well, we're not going to stick it in their liver. Glucagon needs to make its way to the liver, and that's where it will start to pull the glycogen stores. Nitroglycerin. We don't shoot it directly into their heart. It's absorbed under their tongue and has to be sent or distributed to the heart for it to do, actually the heart and the majority of the blood vessels, in order for it to start to do the vasodilation. We also have biotransformation. This is chemically changing the medication through metabolism. And so sometimes the medication gets into our body and it actually turns into something else before it actually does what it's supposed to do. So the primary organ for metabolizing and biotransforming meds is the liver. The liver is very, very important as far as making medications do what they're supposed to do. Some drugs need to go through the liver first before they can actually go to work. Drugs that are ingested, taken in pill format, have to be worked on by the liver, first pass. They have to be worked on by the liver in order to actually be put to work. Things like inhaled medications, albuterol, or IV medications, say even Narcan, those get to bypass the liver in many cases and go directly to where they need to go to work. And then the bioavailability is the amount of the drug that is still active once it reaches the target tissues. Because your body's already working on it. From the moment that it gets in the body's already working on changing it and potentially getting rid of it. So how much of it actually makes it, that's where sometimes dosing becomes a very important science. It's determining how much is there actually still left when it gets to where it needs to go. There's a drug that paramedics give called adenosine. The adenosine is used actually to stop your heart when it's in a very, very fast heartbeat, tachycardia. But the life of adenosine in your body, if it doesn't make it to the heart within 10 seconds after you give it IV, it already has been deactivated. So it's one of those drugs that we slam it in and hope that it gets to the heart quickly. And then elimination. Medications called metabolites are excreted from the body, mostly in the urine, but occasionally through respiration, feces, perspiration, the mammary glands during lactation. So some of it is gotten rid of that way. Good example of this is when you drink alcohol. Alcohol, you can do a urine test, and if you are been drinking very recently, they're going to find metabolites in your urine, but also through your respiration. You will burn off a lot of this through the process of respiration. So it doesn't matter how many pennies you put in your mouth or how many wads of gum are in your mouth or putting a dirty sock in your mouth. It's not what's in your mouth, it's what's coming out of your lungs is what they're doing on the breath test. So you can't trick it. So here's an example of receptor and site binding. So this is where a cell has a very specifically shaped lock on it, very specifically shaped receptor, and in this case we've said it's a beta receptor, and we have a molecule of epinephrine that's floating around in there. It finds that beta receptor, it plugs in and says, cool, let's go to work. So sometimes we have agonists that have a greater efficacy, or they like something better. So agonists are pro, antagonists are against. And when one agonist has a greater effect than another, it has a greater efficacy. Sometimes we also have competitive agents. So Narcan, naloxone, for example. Naloxone it fits in the narcotic or the opioid receptor sites. So that heroin that somebody shoots up, the naloxone and the heroin are actually aimed at the same place. And when the naloxone gets there, it's stronger and it has a better affinity. So it will knock the opioids, it'll knock the heroin out, and it will plug itself in. Now, here we have an example of a beta blocker. So this drug is called propranolol, and almost all drugs that end in OLOL are beta blocker drugs. But beta blockers will block those beta agents. So they will, again, like the Narcan I was just talking about, get in there, plug in, and not allow somebody to get in there and do its thing. So in this case, with that epinephrine floating around in their body, with the propranolol plugged in there, the epinephrine can't plug in and it can't do what it's supposed to do. So the pharmacodynamics, this is the way that specific medications achieve their desired effect. And then most drugs, like we mentioned before, bind with a very specific cellular receptor. So they're looking for a very specific site. They plug in and they start a reaction, a chain reaction of how they're supposed to work. So, and then affinity, like I mentioned before, that's the attraction to a certain receptor site. So some have a greater affinity than others. We may also want to talk a little bit about binding. So when we bind with the receptor sites, some of them have a very strong bond, some of them not so strong, so they can easily be knocked out, knocked off. That receptor site theory, specific receptor sites on cells are activated by substances that they have an affinity for, a particular type of receptor, they inhibit or enhance the functions of the cell. So it's almost like, you know, your Green Lantern ring. When you put your Green Lantern ring on, you get your superpowers. Well, when they get their receptor site filled, they get their superpowers. So some types of mechanism of action. They may bind with a receptor site. They can change the physical properties of a cell. They can combine with another chemical substance. They can change metabolic pathways. So by doing some of these different things, they may change the balance within the body. They may change they may change something that maybe was isotonic to hypertonic or hypotonic. That's going to change the way the water reacts around it. They may have something that, well, changing a metabolic pathway. Say, for example, a chemotherapy drug. It's going to change the way that specific tissues can pick up and hold on to nutrients, so how they continue to grow. They may have to combine with another chemical substance, like in the example in the textbook, a very alkalotic medication like sodium bicarbonate administered IV helps neutralize the acids in the bloodstream. Same sort of thing when we take a bunch of Tums, neutralizes acids. The dose-response relationship. There's usually a therapeutic threshold. And the therapeutic threshold, the loading dose is administered to raise the level of medication to in the circulation to a point where the desired effects occur. So what that means is sometimes we give the patient an injection, an IV push of a drug, and once we get the reaction out of them that we want to get, then we'll start them on an IV infusion or an IV drip. So a constant maintenance infusion that will keep that medication at that level that we were looking for. Now, a couple of other terms that we need to talk about. Backing up for a second here. Additional doses. Sometimes we give a patient the same drug. You know, maybe it's nitroglycerin, for example. We give it every 3 to 5 minutes. Well, that gets us the effect that we're looking for. We give it again in another 3 to 5 minutes to keep that effect. And in another 3 to 5 minutes, we give that third dose to keep that effect. Eventually, it gets to be too much for them, but that's where sometimes we're giving multiple doses. A couple of other terms here. Half-life. The half-life of a drug is the time between each dose is determined by how long it takes for the body to metabolize 50% of the peak concentration. So let's say it's not quite this easy, but for demonstration purposes, we'll say we give 2 milligrams of naloxone. The half-life of that would then be how long does it take before there's only 1 milligram left in their body? How long did it take their body to break apart half of what was administered? The therapeutic index is a ratio of the dose of the medication lethal in 50% of the population, or LD50, the dose versus the dose effective in 50% of the population. So that's the therapeutic index. Basically, it's a very, if they have a narrow therapeutic index, they're going to be very cautious in the doses that they give. If it's something, say, like D50, D50 will have a very wide therapeutic index because it's not going to tend to be lethal to many people. Most people will respond just fine to it. Whereas something like, epinephrine. Epinephrine would probably have a narrow therapeutic index because it can have very bad side effects on their heart. All right, so pharmacology is a very dynamic field, changes very constantly. There are always new medications being developed. Other ones are getting removed or being repurposed, or they're finding new reasons why they can be used. And so remember, you've got to stay up to date. You've got to stay current. A couple of influencing factors here. Therapeutic medication or therapeutic effect is what we intended for it to do. So the therapeutic effect, say, of nitroglycerin is to cause some vasodilation, which eases the blood flow and reduces the ischemia in the heart. Whereas the side effect, this is something we didn't want to occur, but we expected it to occur. So something like hypotension or a headache. We didn't necessarily want that, but it comes along with the territory. Some additional factors influencing medication effects. The age. Infants don't have mature organ systems. Their liver's not mature enough. Or we may have the other end of it. We may have an elderly person, their kidneys don't work well anymore, and they're unable to get rid of it. Gender and body mass. Certain patients require more medication to be therapeutic based off of their size. Men tend to be greater weight and muscle mass, so their dosing might have to be a little different than that of women. Pathologic state. Patient has very severe kidney or liver disease. They may not experience the same response because, remember, many medications have to be worked on by the liver to go to work or the kidneys to be gotten rid of. So you may have to adjust a little bit in order, because that patient won't be able to eliminate that drug appropriately. Genetic disorders. People might have a lack of a certain gene. They may have a lack of unable to produce certain hormones. That's going to cause some odd reactions. A good example, there's a drug called succinylcholine, which is a paralytic drug. There's a genetic abnormality that occurs in certain populations that causes them, if they receive that drug, to spike a temperature and shoot way up high and cause something called malignant hyperthermia, which ends up killing a lot of people. Time of administration. When it is given, whether it's given with or without food, it may be absorbed more rapidly. They may want it to be given more slowly. There's certain times of the day it may actually have better effects. And then any psychological effects. Psychological stress can alter the way that the body is going to metabolize it. I'm going to help you. Sometimes we get that placebo effect. So if we get the placebo effect, telling them this should help reduce your pain, or I'm going to give you medication to reduce your pain. It works very quickly. I need you to tell me as soon as it starts to work. This actually can help enhance that expectation, and it can actually give them that placebo effect, make them feel better quicker. Sometimes we have some other effects that occur, like the idiosyncratic reaction. These are very unusual, but they may occur in a very small number of people, but it's hard to predict who it might happen. So say, for example, the drug can decrease white blood cells in a small number of individuals. So something that is watched for, but is not very typical. Iatrogenic agents, iatrogenic effects. These are any adverse condition resulting from the treatment provided. So sometimes certain medications will actually cause people to have very ugly, one thing that comes to mind, Stevens-Johnson syndrome, where people will actually start to have skin sloughing off their body. It's an iatrogenic effect, something that was completely unexpected, but yet was part of the treatment. And sometimes it's the lesser of two evils. So a couple other terms. Tolerance. This is when people start to build up not an immunity, but build up a they build up a resistance, that's what I'm looking for, to the certain drug because they're more tolerant of it. I think we can all think of people that maybe, say with their alcohol consumption, maybe they started out and a couple beers and they were out cold, and then they continued down that road where it was a couple beers all night, every night, for years on end, and now it takes a case for them to get the same sort of effect, and that's a tolerance. Hypersensitivity, on the other hand, means they react to it very, very quickly and potentially have a very negative reaction to it. So in a sense, an allergic reaction is a hypersensitivity. And so it has a profound effect. Drug dependence is when somebody is basically hooked, where they have a addiction. Drug interaction is when we have a couple of drugs that actually work against each other. So there are some drugs that I think I mentioned earlier, nitroglycerin doesn't play well with other drugs. If you give it in the same line as some drugs, you'll have some very bad effects. A good example, I guess, of a drug interaction would be giving a patient who takes Viagra, would be giving them nitroglycerin. The interaction they're going to have is cause super vasodilation all throughout the body. And then sometimes we get enhancement of certain medications. So we may give a drug like Phenergan. Phenergan can be given to help potentiate or make the effects of like morphine or codeine or Demerol make them work better and have a better effect. So that would be a therapeutic potentiation or enhancement. And we also have cross-tolerance, which is listed in your text. Cross-tolerance would be when you get used to one medication, other medications of the same class probably has very similar reactions. So say, for example, you took Valium a lot, and then they switch you to something like Versed. Versed's probably not a good example. You took a lot of oral Valium, and then they switched you to something like Xanax. Same classification of drug, you may have to go on a higher starting dose of Xanax than you would normally because you have taken Valium for so long. All right, so storing your medications, controlled substances have to be tracked very closely. They have to be accounted for. There's very strict guidelines. You guys aren't going to be carrying controlled substances on just an AEMT level ambulance, but if you're working on a paramedic level ambulance, you're going to be a big process and procedure for how you track and monitor your controlled substances. Medications need to be stored at in the appropriate environments. So knowing what your medications are capable, whether they need to be refrigerated, protected from light and moisture, whether or not they can be exposed to air. It's all something that you have to know about what your system has. Most of your AEMT drugs, as long as you keep them basically at room temperature and protected from light and air and moisture, you're going to be fine. There's really no drugs that the AEMT carries that's going to require refrigeration. All right, so the AEMT needs to know what medications to give and in what doses, how medications act on the body, how the body processes these medications, what laws, regulations apply to the approval and administration of medications, and they need to know what their current medications are.